Welcome everybody to the MENASO educational program academy. This is the continuous education online. It's our pleasure to be with you, and I hope you will get the maximum benefit from this online educational program with the MENA Stroke Organization. It's part of our continuous educational program, and now we are pleased to have two cases. We will start with one case. It will be jointly presented by Ayman Sudani and Dr. Shadi from Egypt, and then this from Ain Shams University. Dr. Shadi is a lecturer of neurology at Ain Shams University, and also Dr. Ayman Sudani is a lecturer in Ain Shams University. This will be followed by another case from Cairo University. I will let my dear co-chair and my dear colleague to present it. Also, I'm co-chairing this with Dr. Ahmed Abdelalim, professor of neurology from Cairo University. Also, I will let Dr. Ahmed Basyouni, my dear colleague, and he's a professor of neurology, and he is the expert in our university in the intervention. He will also discuss these cases with us. If you have any questions, please put it in the Q&A.
First, I would like to thank the committee of the MENASO for always keeping this great activity, and I also thank all the attendees. I see a big number, and hopefully that we will all enjoy this time. Please allow me to present my colleagues, Dr. Nurhan Mohammed, Assistant Lecturer of Neurology, and Dr. Sahar Salah, Assistant Lecturer of Neurology. They are both those who I call the pillars of our teams. They are some of the most active members of our teams. Dr. Nurhan is in charge of following our documentation and quality inside the unit and collecting data for research. Dr. Sahar is also one of our active member teams in the ER and in the unit, and she has just came back from Italy, from Perugia, after her recent training. So our main topic will be the posterior circulation pathology, because it's usually overlooked, and we don't see the cases and manage as much as we do with the anterior circulation. We will see two cases, and I hope they are interested, and then open some discussion on them and see what is the best information that we can get from both. So Dr. Nurhan may start with the first case.
Good afternoon, professors. Thank you so much for inviting me. Thank you, Professor Dr. Ahmed Abdelalim, Dr. Hani Arif. So today we're going to talk about posterior circulation, mainly basilar artery acute stroke. My disclosure, none. I'm going to talk about a bit of introduction regarding basilar artery affection, clinical presentation in general affecting basilar artery occlusion. I'm going to talk about the clinical case experience, first case, and then Dr. Sahar will present the second case. And her case will be mainly about fibromuscular dysplasia, and then take-home message. Acute basilar artery occlusion is a very rare disease, but accounts for 1% of all ischemic stroke. It accounts for 5% of large vessel occlusion strokes. Up to 68% of the patients with acute basilar artery occlusion die or remain with severe disability. However, these data may seem relatively new. However, it presents from 2015, and further data is needed. Clinical presentation mainly of posterior circulation can be non-specific. Patient can come with vertigo, nausea, dizziness, headache, or visual complaint. Such presentation may be stuttering, fluctuating, dependent on the collaterals. Later on, after establishment of the stroke, he may present with ataxia, dysarthria, hemiplegia, ophthalmoplegia, or affected conscious level, and bulbar symptoms, and finally locked-in syndrome. Up to 2 weeks before the main presentation, prodromes can occur. Minor strokes or fluctuating symptoms have been described in 40 to 50% of the patients. And then I'm going to talk about our case. She is a female, 62 years old, diabetic and hypertensive for years, ischemic heart disease with 8 stents 3 years ago. She is compliant on single antiplatelet. She had COVID vaccination 2 months ago that we do not know its nature. She presented at us to our ER. On awakening, she slept 8 hours. She came at 11 a.m. with right-sided weakness, vertigo, and vomiting once. Her NIH was 5, classified as minor stroke. Right upper limb was 2, lower limb 1, dysarthria, and facial 1. She was fully conscious, oriented to time, place, and person. She had normal vitals, a bit of hypertensive side, 170/90. And then we performed urgent imaging of CT brain that was normal, and then proceeded MRI brain. Our MRI showed very faint left mesial temporal lacunar restricted diffusion that can possibly explain her presentation of the minor stroke. Her MRA was significantly showing stenosis affecting both posterior and anterior circulation. Right intracranial distal segment was severely stenotic, as well as the left one that explained her presentation at the bifurcation. Also, the top of basilar was severely stenotic, and the bilateral PCA was almost disappearing. Patient stayed 7 hours without any further deterioration of her clinical state, and then at 6 p.m. she developed the new acute symptoms of ophthalmoplegia, severe bulbar symptoms, and started to aspirate, confusion and somnolence, increased right-sided weakness that her NIH raised to 15, alertness 1, questions 2, right upper limb and lower limb severe 4, and dysarthria 2, facial 2, and sensory. The decision was made for urgent thrombectomy without doing any new imaging. Our team decided to go through this decision, as acute stroke may be absent in the diffusion images. They proceeded for the posterior basilar artery and not the ICA regarding the presentation of the new acute symptoms, as it was the one that explaining her new symptoms. She entered thrombectomy within 30 minutes, which means 18 hours from the sleep onset. Combined techniques was done for the thrombectomy. Both stent retrieval and aspiration were done. The image on the right shows the partial recanalization of the top of basilar, and on the left, complete recanalization. TK score was 3 for this patient. Over the few next hours after thrombectomy, ophthalmoplegia resolved completely. She regained her fully conscious level, bulbar symptoms resolved. Her weakness was partially resolved, mainly in the lower limbs. Grade 2 upper limb was still 4, and her NIH dropped to 9. The patient was later on arranged for left ICA stenting, as her CT angiography assured the right subtotal occlusion and ICA 70% stenosis. I'm going to speak a bit about the basilar artery syndrome, top of basilar artery syndrome, as it can be deceiving sometimes. Like we see, our patient mainly presented at the beginning with anterior circulation affection, and then developed the posterior circulation syndrome. Gaze disorders can be presenting early with vertical gaze disorder limitation, forced conversion sometimes, pseudo-sixth nerve palsy, skew deviation, elevated retracted upper eyelid color sign. Mainly this affection is due to the midbrain nuclei that is affected in different patterns. Behavioral disorder also can present in the form of somnolence, apathy and decreased attention, increased sleepiness, and peduncular hallucinosis. The guidelines of American Heart Association, American Stroke Association mainly mentions anterior circulation management, as the trials was done was regarding this matter. If the patient presented within the first 6 hours from last known when, mechanical thrombectomy should be done for the eligible patient. However, this is for the anterior circulation, mainly ICA, M1, and M2 if eligible patient. And if presented within 6 to 24 hours, if the patient is eligible according to the DON and diffuse 3 eligibility criteria, thrombectomy can be recommended. However, this is for the ICA and the M1 and sometimes M2 occlusion. However, basilar artery was not mentioned in the recent guidelines, and further trials is needed. And now my colleague is going to speak about her second case regarding the posterior circulation symptoms as well.
Thank you, Dr. Nurhan, for this case. Why we chose this case to present, it was challenging in terms of patient having both anterior and posterior circulation critical stenosis. There is a problem with the diffusion weighted images very early, especially in the posterior circulation, is that sometimes you may not see the infarction, especially in the posterior circulation, and there are many literature about talking about having clinical evidence of stroke, but not having these diffusion changes for hours. But the misleading thing about this case is that sometimes in most centers, you would jump to the point that it may be the anterior circulation which is causing the problem. We saw this restriction in the temporal lobe, and we should be very cautious about knowing if this temporal lobe restriction is from the anterior or posterior circulation, because the inferior surface is supplied by the posterior circulation. So it was tricky. So we would maybe suggest that when the patient deteriorated, it could be the anterior circulation, but the decision was to go toward the posterior circulation, which we thought that it is the cause of the symptoms, and it really was. When it comes to the criteria, we relied maybe on the diffusion and the mismatch between the diffusion and not seeing a problem with the diffusion and the clinical itself, and we took the risk and have done the case. But of course, there is a problem with the guidelines with the posterior circulation, because most of the trials and most of the work, even the aspect score, is mainly focusing on the anterior circulation. So in the discussion, maybe we could elaborate on how we proceed with such cases. So now I will call on Dr. Sahar to present the second case, and then see what we will come up with. Thank you very much.
Thank you, Professor Abdelalim. Good evening, everyone. I'm really thrilled to be here to present my case in a prestigious meeting. My case is a 26-year-old gentleman. He's a non-smoker. He has a free past history of any medical illness. The patient presented to our outpatient clinic with unsteadiness of gait, vertigo, right-sided hemihypothesia, together with hemiparesis, which was just in a form of mind drift, and lift 6 and 7 cranial nerve palsy. For these symptoms, the patient was investigated, MRI brain and MRA were done, and they showed a small area of left pontine restricted diffusion. MRA was unremarkable. It just showed tortuous course of the vessel, but there was no significant stenosis. So the patient was instructed to start dual antiplatelet. This event happened earlier in 2017. A year later, the patient presented in 2018 to us with a right hemiataxia, left-sided hemihypothesia, and he was compliant on dual antiplatelet for the past whole year. He was also investigated, MRI brain was done, and it showed a small area of right pontine restricted diffusion and bilateral deep cerebral ischemic foci. CT angiography was done, and it showed a beaded appearance of the basilar artery, for which the diagnosis of fibromuscular dysplasia, it was suspected. Also, there was occluded cerebellar branches, proximal segments of PCA, and distal right vertebral artery. Few days later, the patient was admitted to our stroke unit, and during his stay, he developed severe upper limbs and lower limbs ataxia, severe bulbar symptoms, respiratory symptoms, which eventually led to intubation of the patient and drowsiness. CT cerebral angiography was done, and it showed attenuated intracranial segments of both vertebral arteries with occluded distal segments, occluded basilar artery, attenuated P1 segment of left PCA, and referring of the patent P2 segments of both PCAs through the PCOMs. core vessel angiography was performed to confirm the diagnosis of fibromuscular dysplasia. It showed the whole length of basilar artery involving a string of beads mounting to almost complete occlusion at multiple levels of the artery, with significant reduction of the flow in the basilar artery and its branches. Basilar angioplasty was done using a balloon dilatation of the severe stenotic lesion, which was aiming to revascularization. Over the next couple of days, the patient was extubated. He improved as for his clinical status. He was alert, attentive, and oriented with a very minimal cognitive affection in the form of mild memory deficit. His ataxia improved, and he became ambulant aimlessly. Physiotherapy was performed over the next few months with residual mild ataxic gait and left eye ophthalmoplegia. 3 months following him up in the outpatient clinic, the patient showed a stable clinical course, and a follow-up CT cerebral angiography was done 3 months later, and it showed a total occlusion of the basilar artery after the origin of the left anterior inferior cerebellar artery with good filling by the anterior circulation. Fibromuscular dysplasia is a non-atherosclerotic segmental disease of small or medium-sized arteries. On histological level, FND affect the medial layer of the vessel wall, leading to a medial fibroplasia and the appearance of a string of beads on angiography imaging. When it comes to epidemiology, there is very little known on the epidemiology of the intracranial FND. Only 7% of population is affected, and this is based on the registry of the patients who apply for renal donation. The face of the disease is changing from just a rare disease of the renal arteries, accounting for a minority of cases of secondary hypertension in young women, to a systemic vascular disease which could affect any artery, especially the renal artery, the intracranial arteries, coronaries, iliac arteries. It affects mainly women and usually at a young age, less than 50 years, but the age of discovery usually around 50. The neurological manifestation of FMD includes most commonly headaches, pulsatile tinnitus, dizziness, neck pains, or no symptoms at all. Less commonly, there might be neurological events, which according to the US FMD registry includes TIA, cervical artery dissection, stroke, or amaurosis fugax. The management of FMD is still missing. There is just consensus. The optimal medical or interventional management of symptomatic FMD is unknown. The poor knowledge of the natural history of the disease and the lack of randomized trials compared the treatment options is still lacking. There is only updated European consensus for the diagnosis of fibromuscular dysplasia. The 2021 guidelines of the American Heart Association included a class 1 level of evidence C, which recommended in patients with fibromuscular dysplasia and ischemic stroke or TIA to start antiplatelet, control blood pressure, and modify lifestyle. When it comes to comparing antiplatelet and anticoagulation for the treatment of cases of FMD, the CARIS study demonstrated equal efficacy. And for the medical versus interventional management, there is no comparative data evaluating medical management versus angioplasty or stenting for patients with FMD and recurrent ischemic stroke. Only a case series of 7 patients with symptomatic FMD revealed no complication with balloon angioplasty. The take-home message is that More recent epidemiological and interventional studies in MENA region are needed for posterior circulation stroke. We still have no literature on whether the basilar artery occlusion therapeutic window is of longer duration than anterior circulation stroke. Future prospective research evaluating the natural history of symptomatic FMD on medical versus interventional management should be of interest, and it should involve multi-center randomized trials. Special thanks to Professor Dr. Sandra Mohammed, the Professor of Neurology and Neurosonology at Cairo University, and Professor Dr. Farouk Hassan, the Professor of Radiology and Intervention, for the management of the cases. Thank you.
Thank you, Dr. Sahar. This case is an example of not having enough literature or giving the decision based on the situation itself. What happened in this patient is that he had this non-arteritic, non-atherosclerotic pathology, which is long-standing and in multiple segments. So theoretically, intervention will not help with anything. We cannot stent this whole segment. We cannot stent, especially in the basilar. So what happened is that we went for just angioplasty to save the situation immediately, and it helped the patient in terms of recovering from this attack, which caused him to be ventilated. But later on, the artery closed. It was totally occluded. But what happened is that the patient remained clinically fine. What happened is that the angioplasty we were buying some time. We were buying some time for the patient until the collaterals actually compensated for its pathology, and the patient is now doing fine. This is a special situation, a relative situation. It's not something written in the guidelines, but this is what we did. But fibromuscular dysplasia is an entity that should not be overlooked, and it's usually missed in many of the radiology. And we have seen many presentations in our center, like Dr. Sahar said, of course, strokes, and sometimes they come with headaches, and we discover that they are having arterial dissection, which we see sometimes in these patients. So I think we should be aware of that and take decisions based on what we have, because the guidelines does not have a clear scenario for these cases, and the treatment is usually relative to the patient and the situation. And I thank my colleagues for presenting these cases, and I will now leave the microphone to Professor Hani and to Professor Bassiouni to present the cases from Ain Shams University.
I guess Ahmed, we can have if there is any question regarding these cases, probably we can go for discussion or some comments upon these two cases. I totally agree with you that the posterior circulation is still I can call it a mystery, because it's lagging always behind the anterior circulation, especially in the guidelines. We don't know the window. We don't know also whether the intervention, what's the role of intervention, the window for intervention, and again the medical treatment versus the interventional treatment. All these aspects needs further studies and further elaboration, and also the issue of dissection and all these things. So that's very important also to have our own data in the region, in the MENA region, to elaborate more on these issues. Probably there is a few questions regarding these two cases. Maybe we can take them, Dr. Ahmed, and address these questions before we move to our next part. Maybe Dr. Ahmed is not here.
I'm with you, Dr. Hani. I'm just reading the questions.
Because it's a long questions, I see.
It will take time.
Yeah, there is many questions popping up.
Okay, so I will take the shorter question. Why the patient was on dual antiplatelet for 1 year? The patient was not treated first in our center. He went for another center, and which is not specialized, and this is also important on the merits of having a stroke center, a specialized stroke center, because the experience and the decision making will be much better. They dealt with the patient as if he's just a regular stroke, although he didn't have any enough risk factors. So they just put the double antiplatelet and then send him to come back maybe for the outpatient after some time. but they overlooked maybe the changes in the arteries. They thought it's not significant, but since not treating the patient in a specialized center, maybe the patient was not treated well. Of course, the role of the antiplatelets in such non-atherosclerotic pathology is not really effective. And we just put it sometimes because we have nothing maybe to put, but the double antiplatelet, I think it was not indicated maybe, and was not in our center. Maybe they thought he had some stenosis or something. They put it just like that, but they did not really diagnose the case until he came to our center, and we started suspecting that this is FMD, and the angio proved that and revised back the history, and that's what happened. The second question, I think it's the three of them are the same. He said, I'd like to see the CT in acute stroke cases to rule out bleeding. I think the patient has done a CT in the beginning. And if the patient is in the window, we don't wait for MRI, of course. We have an MRI protocol and CT protocol. So just we go to the MRI protocol maybe when having protocols like the wake-up protocol. And sometimes we use it instead of the CT angiography after maybe 6 hours, and even before 6 hours for the diffusion clinical mismatch, which would be a decision-making point in thrombectomy beyond 6 hours. And for the aspect score is different in the MRI or the diffusion, and from the CT, it's usually get lower numbers. And for the thrombectomy, it's less. It can be 6 and 7 and 8 in the CT and 6 in the thrombectomy. So there is a difference. Another question saying that would you investigate for fibromuscular dysplasia in female patient presenting with this section? I think in any case of this section, we would consider if the patient does not have enough justification or a problem like let's say a trauma or something that would justify, we will look for fibromuscular dysplasia maybe, and that's why maybe some of these patients we will not just rely on MRA or CT angiography, and we will go to angiography in most of these patients to be able to see well the dissection and if there are an underlying pathology that causes this problem.
So maybe we can, if there is more question popping up, probably we can take all the question at the end. Now I will let my dear colleague, Dr. Ahmed Bassiouni. Dr. Ahmed, are you there?
Yes, Dr. Hadi, I'm here.
Okay. So I will let my dear colleague, Dr. Ahmed. Dr. Ahmed is a professor of neurology and intervention in Ain Shams University, and he is actually the lead of our team in Ain Shams University. We have 7 independent operators in our center, and these 2 lecturers who will present these cases, actually they are working with him. So I will Dr. Ahmed to present to Dr. Shadi and Dr. Ayman Al-Sudani for the coming cases.
Thank you, Dr. Hani. We will start the case with Dr. Ayman Al-Sudani. He's a lecturer of intervention neurology in the Department of Neurology at Ain Shams University. And he will start presenting his case now. Are you ready, Ayman?
I will try to share the presentation.
So first of all, I feel very grateful to be a part of this great gathering under the supervision of my great professors from all over the MENA region. So presentation of the case that I present is titled "Too Good to Be Treated." We are talking about a 48 years old gentleman with a post-medical history of controlled hypertension, presented to our emergency department by 3 hours of dysarthria and facial droop. That makes his NIH stroke scale of 2. Blood pressure was 150/90. That was his initial non-enhanced CT brain. It was looks free. So the thoughts that we have, should we give IV TPA to the patient or not? Number 2, should we do a vessel imaging or not, like a CT angiography or an MR?
Shadi, your presentation is not advancing, so probably you should click on the full screen.
Okay. So it's a 48 years old male with post-medical history of controlled hypertension, presented to our emergency department by 3 hours of mild dysarthria and facial droop, making his NIH stroke scale of 2 with blood pressure of 150/90. His initial CT, non-contrast enhanced CT brain looks fine. So the thoughts or the questions that we have, should we give IV TPA or not? And should we give or should we order a vessel imaging for the patient or not, like a CT angiography or MR angiography for this patient? So due to the very small deficit, we decided to conserve, but we usually in our center do a vessel imaging for all the patients presenting with stroke. That's what Dr. Ahmed and Dr. Hani had taught us to do. So we did an MRA for this patient, and we saw this picture of an occluded or non-visualized left internal carotid artery, a very small area of diffusion restriction in the insular area. So we had a lot of discussion whether we should proceed to thrombectomy or not, but the decision was to wait and see. We have a discussion with the family and about the risks and the benefits, and we decided to give the patient full observation. We give the patient loading dose of clopidogrel, 375 milligram, with permissive hypertension, and admission to our stroke unit with a very careful observation by a dedicated neurology resident with repeated NIH score scale every 30 minutes. Statin therapy, dual antiplatelet therapy, that was our plan, and just careful watching was our aim. However, the next day, the neurology resident have noticed a change in his neurostatus. 18 hours since last known well, our team was notified by increase in his NIH stroke scale with added aphasia and right side weakness. So his neurostatus was a dangerous thing. It will jumped actually from 2 to 16. So we decided to repeat the imaging to see what happened. Actually, there was an infarction area started to appear in the diffusion restriction in the temporal area with the same occluded internal carotid artery. The flare was free, so that was indicating that this area of infarction is relatively new. What's called, or what Dr. Ahmed Basyouni have teached us, what's called the tissue clock, that it's appearing at the diffusion. There's a mismatch between the diffusion and the flare. So we decided to push the patient toward the angio suite. The first run showed an occluded intracranial internal carotid artery from the supraclinoid to upward. We did suction and it opened a little bit, but still an occluded M1, left M1. We decided to proceed with the microcatheters and the solitaire stent retriever. And actually, the final result was full canalization with a TIC score of 3B, with full canalization of the left MCA, and the outcome was good angiographically. Regarding the follow-up CT brain, there was a PH1 type of hemorrhagic transformation. Still, this was the same area of diffusion restriction that we have seen. The rest of the hemisphere was saved. Actually, the NIH of the patient post-procedure remained the same. However, 48 hours later started to improve to 14. 3 months later, NIH was only 5 with the MRS2. And still the patient was showing improving day after day. So the key points that I was trying to clarify in my presentation, or that's why I pick up this case in particular, is that 20% of the patients who are presenting with NIH less than 6, 25% of those type of patients harbored a major vessel occlusion or a large vessel occlusion. So all the patients with this NIH score of 2 or above should undergo an angiographic imaging in order to detect the 90% of proximal occlusions. I'm talking about M2, I'm talking about M1, I'm talking about ICA or even basilar. From these patients, 22.5% declines within the 24 hours, 33% decline during the hospital stay, with a 6% mortality and 41.2% mortality, decline in the 3 month, which is a huge percent. So the patient like walk into the emergency department walking, and you just fine, have some facial droop or some mild weakness, and he will be discharged as a bedridden patient. So the acute vessel imaging is a priority for every patient. There was no, like, we have a NH cutoff value of like 6 or more. However, less than 6, 25% of them harbored a major vessel occlusion, and if left with no careful observation and immediate intervention, they will rapidly decline. So here, there are two terms in literature started to appear: the IMT, or the immediate mechanical thrombectomy, versus the rescue mechanical thrombectomy in the end. And all of you know the end is the early neurological deterioration. It's the short name for that. Thrombectomy versus medical management in a low NIH. Regarding the TPA, it's already have been decided in the PRISM trial that giving TPA to very low NIH stroke scale patients does not improve much of the outcome. But regarding thrombectomy, it's still controversial. And some studies like postulated doing a stress test, like some perfusion studies or something, to detect whether the patient will decline soon or not. There's like a published case of like an M1 occlusion with a normal CT, but with a perfusion deficit, a large perfusion deficit, and that patient underwent the thrombectomy with a very, very good recovery. So there's two trials going on, the MOSTI trial and the ENDOLO trial for the low NIH ischemic strokes for NIH 5 or even less. And still no published data about these items, but these two trials are very promising to see whether we do an immediate mechanical thrombectomy for those kind of patients, or we should wait and see and do a rescue one if NIH is declining. The take-home message is that every patient presenting with ischemic stroke or even a TIA deserve a vessel imaging. Some authors recommend best medical treatment. Some authors recommend immediate mechanical thrombectomy in those patients with very low NIH and harboring a major vessel occlusion, or what's called too good to be treated. The development of markers of possible decline, such as the collateral status, the perfusion study, can guide in the future, in addition to the results of the two ongoing trials I've been talking about. All authors know, there's no conflict in that all people recommend close observation for those kind of people, very careful observation in a stroke unit with a dedicated neurology resident making NIH like every 30 minutes, and rescue a mechanical thrombectomy if any declines happen. Thank you so much.
Thank you very much, Shadi, for this interesting case, and I guess this will raise many questions. So now, Ayman, if you are ready, you can present your case.
I will try to share.
I guess Shadi should first unshare his presentation, then.
Okay.
Maybe we can have a couple of questions till you prepare your case,
Okay.
Ayman.
Okay.
Somebody's asking why waiting not to start TPA. I guess Shadi answered this in his presentation according to the PRISM study.
Can you answer Shadi or
Shadi, are you with us?
Yes, sir. Yes, sir.
Yes, I guess.
Shadi?
Yes, sir. The question is that, is this capsular whirling syndrome required IV, TPA, and angio? So actually, the patient was presented with only dysarthria and facial droop. and by the time of admission, these symptoms even disappeared. So regarding if we have noticed the PRISM trial for repeated TIAs and NIH score less than 4, it's not advisable to give TPA unless there is a significant disability. Like if the patient have only visual field defect and is like a driver or an engineer or a surgeon or something, I will give TPA. But for some dysarthria which is already resolved, like the patient have already been NIH 0, so I will not risk TPA in this case. If Dr. Hani agrees with me, of course.
Yeah, yes, definitely. According to the PRISM, I mean, we should wait not to give TPA according to the study. But I guess this raised, especially in such situation, this will raise an important problem. Is each case should have angiography, at least CT angio, from the very beginning, because this would be a very important clue if this patient is likely to deteriorate, especially if this patient is having M1 or M2 occlusion, total occlusion. Probably we should keep an eye on him even, and any further deterioration, probably we can intervene immediately. But the issue whether we should intervene, and I guess this will raise another question. If we have this occlusion and still the deficit is very minimal, I guess this will need more studies and to elaborate on this. Dr. Ahmed Basyouni, you are the expert in this area. What's your opinion?
Yes. For me, every case with acute stroke, I should go to further CT angiography or MR angiography, because it helps us to understand much more about the pathology of the disease, and also it helps us a lot to expect the prognosis and the near follow-up of such patients, and the need to be ready for further intervention or further medication. The second thing about the TPA, I think in such cases TPA is not advisable unless we had the decision to do thrombectomy, because TPA will not open such a huge occlusion from the internal carotid into the mid-cerebral artery. It will not work, but in such cases it can help us a lot to dissolve the thrombus or to facilitate the thrombectomy procedure, especially if we are sure that the patient does not have dissection or does not have a source of embolism from the heart. So it will help us a lot, and it will facilitate our procedure a lot.
But if you are having a M1 occlusion and with a minimal deficit, you will go for thrombectomy.
No, if I have M1 occlusion and minimal deficit, I will wait and see.
Wait and see.
And I will do a very close observation for the patient.
Very close observation. I guess everybody's agreeing. Yes.
Because in our region, especially, we have a lot of intracranial atherosclerotic disease, which is chronic, and we face many cases with acute on top of chronic lesions. They are already compensated with good collaterals. So doing the intervention in such cases is risky, and maybe it will not be beneficial for the patient. The greater percentage for such patients are having good prognosis and good recovery.
I can see till also Dr. Ayman preparing. Probably, I don't know whether Dr. Ayman can you send the slide to the organizer so they can present it, or it's difficult? Anyway, if Dr. Ahmed Abdelalim was us, I guess there is some questions regarding the early two cases. Can you take them, Dr. Ahmed, till we...
Okay, Dr. Hani. I think one of the questions is why I think the first case didn't take RTPA after the lesion appeared, because the lesion in the temporal lobes were a bit misleading, and also there has been enough time that passed over it. So taking the decision to give RTPA at that moment will be a bit dangerous, and I think it appeared in the flare, some of it. So this is an established stroke, so you cannot give RTPA after having further deterioration or another stroke within the same window. But the thrombectomy can be done in this case. And I have been recently discussing a case with Dr. Basuni that we had in our center, is that the patient presented with a stroke in the left MCA, and he had AF. And then 2 days later, he received RTPA for that stroke. And he showed some improvement, but 2 days later, he had another stroke on the opposite side. So on the opposite side, we cannot give RTPA, but we can still do thrombectomy in this situation. So this is a relative situation that we have. The thrombectomy maybe have maybe different criteria, and sometimes patients may be on anticoagulation and things like this. The RTPA is maybe more restricted in some cases with LVOs, especially beyond the window of 4.5 hours. And so in this case, sometimes we cannot give thrombolysis, but we can do thrombectomy, and this was the decision in this case. Of course, some of these decisions are relative and may be debatable, and sometimes we may discuss ourselves if this was the best or not, and this is how we learn. We go back and check our decisions, and there should be an improvement in our decision making over time, and that is one of the merits of having a stroke center, because the cumulative knowledge will help to get more a better practice in the future. I think also it's the same question that somebody is asking about, why the patient took dual antiplatelet, the second patient, the fibromuscular dysplasia, because he was not treated in our center. He first came to us after being treated in a general hospital. So they saw some changes in the basilar. They did not identify, so they thought it was just an atherosclerotic stenosis or something. So they put him on dual antiplatelet, and then he had another stroke. So he came to our center, and we identified this suspicion of fibromuscular.
Maybe this question, Dr. Ahmed, because of course, with the dual antiplatelet and the new guidelines, and also even with the Sampras study, the maximum duration is 3 months. But but actually, and it's common practice in Egypt. I don't know whether in the rest of the region, we noticed that many of course this is offline, but many of our colleagues and physicians are giving dual antiplatelet for longer period. And actually, we didn't notice any serious side effects from using this dual antiplatelet for long periods, especially in high risky patients with multiple risk factors. And also, we are having a lot of cases with intracranial stenotic lesions. So this is a common practice. Also, we are having in the region silistazole. So it's again common practice to give clopidogrel plus silistazole or silistazole plus aspirin, I guess. I don't know whether Dr. Ahmed is agreeing with me regarding this point.
Yes, and I think in our last stroke conference in November, we had this debate as, of course, the guidelines says that we should not use the dual antiplatelets for a long time. But what happened in our region is that usually these patients are maintained on dual antiplatelets, most of them maybe not because of the stroke, but because of cardiac problems or vascular problems. So we are under pressure of continuing. And sometimes maybe we're afraid to stop one of the antiplatelets. But actually, yes, our observation in our practice, although this is an unpublished or maybe unvisited actually scientifically way, but the observation of all of the neurologists in the who were actually some of the most important and neurologists in the region, in Egypt and in the region, they all agreed that they actually do not see this problems. The major bleedings usually get some ecchymosis or epistaxis that are not usually dangerous. So I think we need a study on this in our region, like a retrospective or a prospective study on seeing patients who are on dual antiplatelets maybe for other reasons, like cardiac problems or peripheral vascular for longer than 3 months, and then we see if there are in our population if there is really the same risk that was mentioned in the guidelines or not.
I guess, Dr. Ayman, you succeeded in sharing the presentation, but I don't know. Anyway, there is another question, I guess, for Dr. Ahmed. Dr. Ayman, you can you share your presentation?
Yes, Dr. Hayy.
Yes, share it. So the last question, maybe we can take some questions after the presentation of Dr. Ayman, the case of Dr. Ayman. Please, Dr. Ayman, present your case.
Can you see the slides?
Yes. Go ahead.
Thanks for the chairman, and thanks for all the MENA Stroke Organization members. I would like to share one of our cases that we did at Ain Shams University. This is our stroke unit. This is our angiography machine. This is a case, 44 years old male patient, heavy smoker with relevant past history, presented with right hemiparesis and global aphasia for 3.5 hours duration. CT brain showed no recent hemorrhage, and his aspects was 10. The patient NIH was 15. After revision of the inclusion and the exclusion criteria for intravenous thrombolytic therapy, the patient was candid, and he received a full dose of alteplase. This was in a remote hospital. After finishing alteplase, the patient didn't improve and transferred to our institute for possibility of having large vessel occlusion for further intervention. At our institute, our initial assessment revealed that the NIH is still the same, 15. Immediately CT cerebral angiography was done and revealed left middle cerebral artery M1 distal M1 occlusion, and the aspect still 10. A decision for mechanical thrombectomy was taken, and the patient transferred immediately to the angiography suite, and groin puncture was done after 9 hours of stroke onset. As a matter to save time, we initiated the procedure under local anesthesia. The initial angiography showed left MCA distal M1 occlusion. Unfortunately, the videos cannot. I think the videos cannot work. I will see some pictures. This is the initial imaging. As we see distal M1 occlusion. This is the anterior view, and the left image is the lateral view. You can see the vascularization of the whole left MCA territory. By time, the patient became more agitated with a frequent movement, so we called for anesthesia. The procedure was shifted to conscious sedation. The materials we used: an 8 French sheath and 5 French diagnostic catheter, a guide wire 0.35, and a guiding catheter and 8 French, and an aspiration catheter called Sophia 6+. Again, the images does not work. We placed the guiding catheter at the left internal carotid artery under continuous saline infusion, and introduced the aspiration catheter inside the guiding catheter, and was navigated till we reach in contact with the thrombus. Through the using of 20 milliliter syringe, one attempt of manual aspiration was tried, and we succeed to achieve complete recanalization of the left MCA, TK3. This was in less than 15 minutes. Again, these are the images, the initial images as we see left MCA1 occlusion, and this is the images after one attempt of aspiration, complete recanalization of the MCA. Here we can see the anterior view and the lateral view. Follow-up CT brain after 24 hours revealed no hemorrhage, and the patient clinically improved gradually and discharged after 10 days with NIH of 3, remaining just some sort of expressive aphasia and flattening of the nasolabial fold. These are some points to discuss. to give intravenous thrombolysis before mechanical thrombectomy or not. The latest guidelines of the American Stroke Association and the European Stroke Organization guidelines states that we should give intravenous thrombolysis before mechanical thrombectomy. But still, this topic is still a matter of debate. Some papers encourage giving TBA and others disencourage giving TBA. The latest SWIFT direct trial results, it is still an ongoing trial. It's preliminary results presented at the European Stroke Organization conference on September 2021. It concludes that no reason to drop RTBA in stroke thrombectomy. The rationale was that there is no increase in the rate of symptomatic intracerebral hemorrhage, and still there is a possibility of recanalization in large vessel occlusion with intravenous thrombosis, although it is low, but there is a possibility, and there is a possibility of failed thrombectomy due to many reasons, access, difficult access, and other reasons. But still, there is after all these papers and trials and guidelines, the subject is still a matter of debate, especially in some type of cases, those with tandem lesions and those with resistant thrombectomy. In both cases, we may stent the extracranial carotid artery in tandem occlusion, and we may do rescue stenting in those with resistant thrombectomy. The problem is that in those cases that we will put a stent, we will give intravenous antiplatelets, which will increase, together with the TBA, will increase the rate of symptomatic intracranial hemorrhage. Until the availability of randomized clinical trials, especially in those type of patients, this issue will remain debatable. And the second question, in patients with suspected large vessel occlusion, to wait or not for signs of improvement after intravenous thrombolysis, the guidelines answer this: not to wait after the negative CT brain, immediately start in intravenous thrombolytic therapy and do CT angiography. If there is a large vessel occlusion, move the patient immediately to the angiography suite, stop the drip just before groin puncture. But in our case, they wait, but as they were in a remote primary hospital. Thrombectomy in the extended time window in low resource settings. As we all know, the latest guidelines of the American Stroke Associations and latest European Stroke Organization guidelines encourage us to follow the criteria of Dawn or diffuse 3 trials in doing thrombectomy beyond the extended in the extended time window. Dawn trial depends on clinical radiological mismatch, and diffuse 3 trial, it is a pure radiological criteria. But in low resource settings, if we don't have MRI machine, if we don't have perfusion studies, can we do thrombectomy based on CTA and CT aspects? This is a nice paper which promote doing thrombectomy for those type of patients depending on clinical aspect mismatch. If the patient's aspect the patient NIH is more than 10 and the aspect is more than 6, there is a clinical mismatch even in the extended time window. And as in our case, the patient NIH was 15 and still 15 until he arrived at our hospital, and the aspect was 9, 10, and still 10 even after we repeat the CT, we do CT angiography. So we encourage to do thrombectomy and confirm the presence of good collaterals during the initial phase of angiography. To do thrombectomy with local anesthesia, conscious sedation, or general anesthesia, the guidelines didn't select a standard method for anesthesia. Let it to the decision of the operator. It is with local anesthesia or conscious sedation or general anesthesia. No preference of certain methods. Every operator selects the convenient method to do aspiration thrombectomy versus stent retriever thrombectomy. The guidelines, the classical guidelines was with stent retriever thrombectomy, but aspiration thrombectomy can be another option. At our center, we use the available materials if it is stent retriever or aspiration. But if we are in the optimal settings, we commonly start with aspiration thrombectomy for many reasons I will mention. And if we fail to complete the procedure, we shift to stent retriever thrombectomy. The advantage of aspiration thrombectomy, it is cheaper. It is very, very, very important. It nearly has the same efficacy as stent retriever thrombectomy. No much technical difficulty. It is slightly safer and it is slightly faster. It is slightly safer. No injury to the vessel wall, especially if the patient having TPA. No reduction. There is the reduction of a new embolization, whether in the same territory or in another territory. And in case of failure, we can follow it by stent retriever thrombectomy. To conclude, there is till now there is no reason to drop intravenous thrombolytic therapy before mechanical thrombectomy. Number two, don't wait for signs of improvement after intravenous thrombolytic therapy. Move the patient soon to the angiography suite. In low resource settings, in absence of advanced imaging techniques, in the extended time window, we might depend on clinical aspect mismatch. As I said, NIH more than 10 and aspect more than 6 to decide eligibility for thrombectomy. Local anesthesia can save time in some cases, but not always. So the availability of anesthesia team is essential for smooth thrombectomy. Finally, aspiration thrombectomy is non-inferior, cheaper, faster, and relatively safer than stent retriever thrombectomy. Thank you.
Thank you, Dr. Ayman, for raising these debates in the issue of thrombectomy. I don't know whether Dr. Ahmed is still with us. If you are, I know you are having a commitment.
Yes.
If you would like to add anything or to take some questions.
For me, I believe that IV thrombolysis in the absence of sure vegetations in the heart or source of recurrent embolism in the heart, or in the absence of the need to do stenting is an important and essential thrombectomy. This is for the first question, and then I am obliged to leave now because I am having a meeting. Yes,
Okay, so I'm extending also the answer to this question. I'm totally agreeing with Dr. Ahmed because this is still in the guidelines, and most of the studies done so far is insisting and putting that thrombectomy, that thrombolysis should be done if the patient arrived in the window of thrombolysis, even if the patient is having a proven proximal occlusion. This is provided that you will not waste time, because time, of course, is very important. And maybe this is will give some advantage, as Dr. Ayman said, because the thrombectomy might fail. Also, in some situations, thrombolysis may be beneficial, especially if we use the tenecteplase. Also, maybe it will help in some fragmentation of the thrombus, and in making the thrombectomy procedure is even easier. And also, if there is a distal shower, probably it will be dissolved by this RTP. I mean, there is, theoretically speaking, some of the advantages which might benefit, and no study proved that the addition of thrombolysis will increase the risk of hemorrhage. All the studies, including the meta-analysis of Hermes, the mega trials of the thrombectomy, and many of other studies didn't prove that there is any increased risk of hemorrhage. So I guess there is any more questions. Maybe there is a question also for Dr. Ahmed discussing about this case. Why in the first place this case was diagnosed as fibromuscular dysplasia? If Dr. Ahmed,
it was based on the angiographic. Of course, the patient did not have any risk factors for stroke, the age, and also having this beaded appearance of the artery, despite not having any other vascular pathologies elsewhere. So I don't think there's any other disease that could present in this way. Maybe in the anterior circulation we do see the moya, which is also from the same entity, which is the non-atherosclerotic arterial disease, and we have also some cases treated in our center. But we mainly focused on the posterior circulation strokes and the spectrum of maybe of symptoms and atherosclerotic versus non-atherosclerotic pathology, and how can we help these patients, especially when the guidelines are not really helping in taking a sharp decision. So we will need to take a decision at that time to help the patient. Of course, it will be a relative decision. And unfortunately, fibromuscular dysplasia has no definitive treatment, and also thrombolysis is doubtful in these patients if they get strokes, because they usually it's an hemodynamic strokes rather than thrombotic or an embolic strokes. So I think in these cases, patient by patient decision, I think, and the learning curve improves by time. And these data I think should be published for the future, because the cumulative data would help the scientific society maybe to add up to the registries and to the data worldwide that can maybe help someday find a treatment for these cases, or just help put a definite guidelines.
I don't know. I guess I can't see any more questions. Dr. Ahmed, if you can see any questions in the Q&A box, or if any of the attendees would like to add more questions.
I think there are many questions about the thrombectomy versus the thrombolysis, maybe. And people may be seeing that they think that maybe the era maybe of thrombolysis is decreasing. So I don't know what Dr. Hani's opinion, but I don't think this is happening, because we can only help the percentage of cases with the LVOs with the thrombectomy. But the thrombectomy has definitely changed the history of neurology, because now we can see that we can treat the worst cases of neurology. Maybe we used to have these MCAs and ICAs dying maybe in ICUs in maybe a few weeks. This was a very sad scenario that we used to see in our practice, but now we do see these patients walking on the legs and talking and having their lives back despite having one of the worst strokes. So yes, the thrombectomy has definitely had its place, because this was a space that we didn't have anything to do. But still, the thrombolysis is the mainstay of treatment, because it works everywhere. It works on larger arteries, smaller arteries, and they can even help the thrombolysis by maybe making the technique easier. And I think it will be a debate for some time for those who would love the thrombectomy alone versus the bridging. This will go on and off maybe for some time, but at the end, the practice is improving all over. I think all of us are now having in stroke centers good experience with these cases, and the learning curve is going higher. And also, thrombectomy is a technique that it's a hand technique. So the experience and the technique itself is improving over time. The operator cumulative experiences and decision making is better now. So I think it's not a competition. They are completing each other, and the wise stroke neurologist would take the right decision in the right moment for the right patient.
I totally agree with you, Ahmed, because, you know, I don't know, sometimes there's a vision for the management regarding thrombectomy and thrombolysis that these two procedures are competitive. As you said, they are complementary. Maybe because sometimes it's done by the interventionist, who is sometimes a radiologist, or he is would like to think that everything can be done by the radiologist, or sometimes there's no role for medical therapy, and you know, all these things which can happen or can be in a debate, but actually they are complementary. I mean, 80% of the cases definitely will benefit only from thrombolysis because they don't have a proximal occlusion. And even in these 20% cases which will present in the window of thrombolysis, there will be, as I said before, no waste of time, and we will do thrombolysis, and there is no harm of bleeding. So the thrombolysis is complementary to the thrombectomy. So definitely these 20% of cases are the most serious ones and the most disabling ones if they are neglected. But still, there is a place for both of the procedures, and it's very important to look at these two procedures that way. These are complementary procedures, and they will go for good, even if we can say at some time that thrombectomy will be only for these 20% of cases and no thrombolysis. But I think this will not be the case. Probably they will go hand in hand even in these 20% of cases. I don't know whether there is any more questions. Yes, if the patient presented with coma, posterior circulation, would you go for thrombectomy? I guess thrombectomy in a comatose patient, nobody will touch a comatose patient. It depends also on the window, you know, because, and as I said in the beginning, still there is a lot of debate about the posterior circulation, and we are not we don't have still that solid guidelines as we did in the carotid and the anterior circulation. So sometimes the patient may be presenting very early with disturbed consciousness. So why not to go, and even, you know, the basilar syndrome, sometimes the basilar syndrome is slowly progressing over so many hours, sometimes even up to 24 hours. So most of these cases actually will depend on the physician's judgment. It will be case per case, and according to the situation, the radiology study, and the general condition of the patient, the clinical presentation, and so on. What's your opinion, Dr. Ahmed?
I think it depends on when the disturbance of the conscious level happened, because sometimes if it's very recent, I think we may be going. Like the first patient that we presented, she was conscious and she has a non-disabling stroke. And then we observed, and at the time that she had this drop of conscious level and this confusion, I think we were ready to perform this. But maybe if the patient is coming, maybe at the end of the window, you have to evaluate and make a decision, because the NIH score will be definitely very high in this problem. But it depends, I think, maybe anterior versus posterior circulation. I think in the posterior circulation, maybe things are a bit loose than the anterior circulation. So I think if it's a very recent drop of conscious level and the patient was fully conscious maybe before that, maybe we would consider if he's indicated. If not, then nothing to be done, of course. And it's definitely a difficult situation to go with a comatose patient who may be on a ventilator or something. This will be a difficult situation. I think in all cases for our audience, that if you read the guidelines, scenarios maybe are clear and defined, but this is not the real life experience. This is not what happens. Every patient in himself is a case, and the decision making can be very difficult in this perspective. So I think we will have to take case by case and then go back and revise our decisions to make sure that we are going the right way, and revise the guidelines and try to adapt them to every patient, not in a blind way, but in a maybe an effective way, so that we don't skip treatment for patients who need, or give treatment for patients or over treating patients without a reason.
Somebody is also asking about short statement about risk factors. Of course, all of us know that there is non-modifiable risk factors and modifiable risk factors, and of course, we will not go into this, of course, age, sex, and so on. But don't forget always in the modifiable risk factors, the heart. The heart is of course, a prime suspect, as we always say. And there is a lot of debate now about the ESUS, the presence of AF, and we should document AF, and for how long we should monitor the heart. This is very important, especially if you suspect that this stroke was of cardiac origin, especially with the new monitoring techniques, which can monitor the heart for a long time. So I guess there's no more question, and now we are almost, I guess, in time. So if Dr. Ahmed would like to have any concluding remark, would you?
Thank you, Dr. Hani. I think maybe the most important thing, and I think this is one of the mission of the MENASO and most stroke societies, is that all patients with stroke should be treated in a stroke facility. This is really very important. It's not accepted in 2022 to treat patients with stroke in general hospitals by doctors who did not have enough training on stroke. As you can see, even in stroke centers themselves, the decision can be very difficult. So you can imagine how things would go in a general hospital. So in countries with big populations or maybe low economic state, there could be solutions, of course, like having stroke-ready hospitals and training internal medicine doctors, and the single neurologist can even operate many hospitals. So I think for us and for the region and for developing countries to be able to give a good evidence-based treatment for stroke patients and gain experience and offer its data and experience to the world. And this, I think, will change the guidelines and change everything, because most of the guidelines and the treatments are based maybe on European and American studies with sometimes Asian, some African, and some South American population. But I think we need to contribute more. And meetings like this is how we exchange our experiences. And I definitely thank the MENASO board and Dr. Suhail for always pushing this kind of meetings, and I'm really happy to be here today among our attendees. And I thank again the board and thank all of you gave us their full attention for that time. And I thank you, Dr. Hani, and looking forward to seeing you again in future meetings.
Thank you, Dr. Ahmed. I guess, as we promised, MENASO will always be with you for this continuous educational program. And these waves will come one after another, hopefully in the future with, I guess, COVID now the situation is improving. So hopefully we can even make these meetings more physical meetings, so we can meet you face to face, and we'll have more chance for physical discussion and maybe also seeing real cases. By the end, I see there is more than 1,000 attendees now. It's a great that after this almost 2 hours, still we are having more than 1,000 attendees, and I hope you benefited from these 4 cases we presented. And also I will extend my thanks to my co-chair, Dr. Ahmed Bassiouni. He has another meeting, actually he has to leave. And of course, our young neurologists who presented these cases, Dr. Nurihan, Dr. Sahar, Dr. Shadi, Dr. Ayman Sudani. Hopefully to see you soon in the coming waves. And goodbye and good night for everybody.